We're on.
Hi.
Loyal fans.
Hey. Hi.
Hello.
Hi.
What
We're
up?
live.
Here we
This is a
are.
great talk
Welcome.
show. It's very formal. Yeah.
Do you know I have never actually watched a full episode of a real talk show
Ever.
Not,
ever? Like
not
I've seen
What?
like clips. I've
not
never
even
like I
like
don't
in
even
high school, like Jerry Springer, like when you were having a day, like, no,
I
I'm
mean,
serious, like, or
Melissa's
Maureen, Harry
example.
Potter. That's a talk show.
no.
That's
No, I've never seen a whole. I've seen like clips. Also, like I'm not lying. I grew up in the middle of nowhere. Lisa grew up in more of middle of nowhere. I had four TV channels, like legit. Like there wasn't much going on, so like I kind of missed that out. And then, yeah, I just like I have no
I didn't
idea.
have any TV at all, so I don't know what you're talking about. Like, I didn't
Well,
have
you also didn't
TV,
have
didn't have
electricity, so
electricity, didn't
wow.
have all the things. So, no, when I first got
Lisa,
TV, like as a teenager, or an old teenager in college, I was like, TV all the time. It was amazing.
yeah.
It was
Yeah. I
great.
mean, the internet
Yeah.
also happened to me. Like the internet happened
Right,
to me
right.
like in
Yeah.
college, and like it was almost like what's the point in watching TV at that point? So
Mm.
but the what's his name? Joe Grogan, not to be confused with Joe Rogan, who we interviewed and he interviewed us. He was like, "Did you guys like base your show on Car Talk?" I have listened to
Oh,
Car Talk because I
yes.
could get
But
NPR.
actually, to be fair,
Okay,
I
That
also listened
counts.
to Car Talk. We didn't have TV, but we had National Public Radio, Car Talk,
Yeah,
that's
all
right.
the
that's
time.
right.
Yeah.
Yep.
Yeah.
Love
That
that.
must
Hey,
be what it
wait,
is.
is NPR going away now?
Is what?
I mean, I hope not.
Diversifying,
Yeah, gotta
diversifying revenue
diversify their
streams.
revenue. That's right.
Yeah,
Yeah.
right.
Cool.
Yeah.
They'll make it. Yeah, well, that is a shame because as a rural American, I did actually, that was one of the channels I could get, and that is how I learned things
Car Talk.
about my car
Yep.
also. Anyway,
That's
okay,
right.
so we have the amazing Kamal on our show. She's our special guest. She's gonna tell you more about herself later. We're gonna put her behind the screen so we don't get anyone in trouble except for ourselves. Melissa, anything new and exciting today to tell us?
No, tip us, please. There's lots.
Send us
Tip us,
tips.
tip us, be a sponsor. There is a guest form. I will drop everything in there. I would love to have you on the show. I would even love it more if you paid us to have you on. Thank you.
Thanks, Melissa. See you later.
That's right. Just she's handling
Oh,
the commercial side of the Health Tech Talk show, which is,
yeah.
to be fair, very minimal.
Yeah, and definitely something we are not excelling at. But like
Even less than public radio, you guys. Even less than public
yeah.
radio. That's
Yeah,
right.
listen, yeah, we could do a pledge drive. Like
Listen.
anyway, yeah. Okay, Lisa, I just got back from Alaska like at 8 o'clock this morning. And you, I assume, have been recovered from your journey across multiple continents. So this is
Yeah,
probably going
I
to
mean,
be a
I will
great talk
say,
show.
yeah, I did suffer a bit from the old jet lag, but it wasn't too bad. I mean, I just would get a little more tired in the afternoons. And you know what? I'm also always tired in the afternoon, so, no big difference.
Yeah, 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 yeah.
All
But
good.
anyway, here's Lisa and me. We are clearly hiking through the Kenai here with some friendly bears, which did happen one time, and we also got money out of the Alaska USA ATM
That's
located in
right.
Anchorage. We posted that picture many times on the internet. So yeah.
That is
Okay,
correct.
so like a lot happened while we were gone. Thankfully, Lisa actually told me about it because everybody knows I don't pay attention otherwise. And then we had our new friend, maybe he's our old friend, Christian from
Now we're
Insight.
old friends at this point.
Yeah, I mean we're like we've been texting for a while. Anyway, so he sent us his scoop that he got here. I think a lot of people have heard there's a meeting next week. It's going to be super fancy, allegedly, about getting industry to pledge to do some interoperability. Lisa, what do you think about this?
Yeah, I mean, we had this pledge, this health insurer pledge and prior auth, blah, 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 a few weeks ago, whatever it was. And, it seems very clear that the vibe and the direction from HHS is to say, and probably I assume from the White House as well, is to say, hey, industry, you better sort it out because if you don't, we're going to do mean things to you. And so they're kind of like giving people like a public option to pledge to do stuff, and then if they don't, like, we'll see what the TBD is.
So
So
police.
self-police or else. I think like for me, most important is like the or else. Like I want to see a little bit of, I want to see a little bit of teeth. I want to see a little bit of teeth here. But I'm all for a pledge, and I'm excited to see what some players who we know of say and what they do at this event. Fingers
Yeah,
crossed.
I want to see what's going to happen because,
That's
as
right.
Kristen notes in his piece, which you should subscribe to, help a guy out, help a reporter out. He notes that no one was willing to share the actual pledge. So, who knows what's going to
Yikes.
happen? Who knows?
Who
But yeah,
knows?
like Lisa said, that I think last or earlier this week, Dr. Oz and Dr. McCary they wrote this op-ed in the great American Wall Street Journal about how they are using industry to get things done. I actually think, like, I know people are like, wow, this doesn't work. I don't think anyone's really tried like they have. So, and I haven't seen the government actually collaborate or negotiate with industry like this before. So I think it's great. Like, it's worth a try. And honestly, if it doesn't work, then they can just go regulate. So,
I
seems
mean, I totally appreciate these efforts, right? Like I don't want to downplay. I think you do have to say like, okay, like here's what we want you guys to do. Like let's talk, let's make it happen, right? You do have to say that. Now, I
yeah.
think that the or else is important here too, like I just said, but like sure, this is the first step, right? Is saying like, guess what, guys? It's
Yeah.
time.
Come on over. And we
Come on
also,
over.
Lisa, we had some loyal fans ask us if the rumor is true that this interoperability pledge would be called something along the lines of the Freedom Health Data Network. I can
Who
neither
can
confirm
say?
nor
Who can?
deny.
Yeah,
I
we can neither confirm nor deny. Of course, as we have said many times in public on this very show, we have offered this amazing brand to the US government for no charge in perpetuity, Freedom Health Data Network. Run with it. Like we would be
uh-huh.
very happy to have credit, but also we're not asking for any money. We just want we want data to move, and we're big fans of the Freedom Health Data Network.
Yeah, and I feel like this is an all-American kind of title. Also, our bestie and favorite unpaid correspondent, Michael Marchant, has actually purchased the domain for this. So we will give it all to you, federal government. You just like
Listen, we don't want
you know how to
anything.
find us.
Yeah, we you know how to find us. Carrier pigeon, signal, text, call. You come to our houses. You know where we live. Like
WhatsApp,
whatever.
Telegram.
What's up?
Yeah,
Just
you
come
can
and
find us. You
we'll
can find us.
happily.
LinkedIn DMs, well, anything you need. We are here for you. We will transfer these assets pretty much immediately. So
Right.
but anyway, we're looking forward to hearing if if this is on some big screen this coming week at the White House. Like, I don't know what's going to happen.
I
But
honestly like I cannot tell you like it's been a kind of a rough year, honestly. And like if this happened,
mm,
I would be it would make my day, it would make my week, it would make my year, it'd make my decade. So like please help
yeah,
help a girl out.
yep. I'm just saying, can't confirm or deny, but this would be the greatest professional thing that happened to me, like probably
God.
in the past year. So just call
Oh,
us. Here we are.
just call us.
Okay.
Okay,
Call us
great,
later.
great.
Okay. All right. So there's some other like stuff that happened. So okay, Lisa, I will say the title of this fact sheet is so douchey. Like, I would have maybe not written this that way. However, I actually read the fact sheet, Be Impressed, approximately 20 minutes ago. I know, but I only read the fact sheet. I didn't read anything else.
I'm not sure if that
Um,
okay, fine, whatever.
it's
Sure, keep going.
actually not as douchey as the title sounds. It's more like there's like they're gonna put out more funding to go to SUD facilities and
Cool.
hopefully get people off the streets into treatment facilities, like not into prisons, which is originally what I thought was
Mm,
going to happen here. So
yeah.
I don't think it's. I'm not sure why it's written this way, unless I'm just being hopeful in my reading of the fact sheet.
Yeah, I mean, listen, this is a like really complicated issue around homelessness, around continued, drug use, addiction, overdose, like showing up on the streets. I guess I would just say like I respectfully put forward that you don't solve the problem by just like getting people off the streets or like putting them in a jail rather than letting them be on the streets or pushing them somewhere else. Like there are root causes that have to be addressed. It's not fun, it's not sexy, it takes a long time, it's complicated. There's no simple answers here. So like I'm happy for us to do anything else we can do on services to get people off the streets, but like law enforcement is can't be the only solution, basically. That's my response.
Yeah. And again, I encourage everyone to read the fact sheet because it talks all about like getting people into treatment as opposed to other things. But it's definitely pro getting them off the street and having more means for localities to actually get them off the street. So
Did
I
you, on this note, wait, did you see there was another article about crime in New York? This is very interesting and like
no.
this is super, like actually crazy. So, not like really serious crimes like murders and serious assaults are dramatically down still, right? There were a few little spikes over the last couple of years, but like, let's just all like center on the fact that like violent crimes, murders are down actually across the country in most places. But petty crime, so to speak, petty crime, shoplifting, things like that, disorder, whatever, is up in many places, especially cities. This is crazy.
Well,
Nearly a third of all shoplifting arrests in New York City last year involved just 327 people, and collectively, they were arrested and rearrested more than 6,000 times. Bro, that's crazy. Like, I feel like there's a problem here that isn't being solved by arresting and rearresting those people, 327 people, 6,000 times. What is up, guys? Come on.
yeah,
Yeah.
that's yeah, yeah, yep. Okay. Well, maybe we'll cover that on a future show. Maybe we'll get one of them to come on the show, Lisa. I don't know. I don't know. All right. Look at this guy's face. It looks like big drama llamas going on in our Congress. So, Lisa, what do you think here? They're all going to try to screw each other. Yeah, throw some mud.
So like probably yes is
That's
the
what I
answer
would
to
do.
what you just said. Like probably yes. But the reality is like I think everybody here, especially Democrats, are really to blame for losing their majority and not doing anything with it when they had it. So, whatever. Sorry, you guys. That's what happens. That's what happens when you lose. You don't get to pass legislation. Wah, wah, wah. Shouldn't have lost. Number one. And then number two, like, cool, here we are, like, okay, so now we have a chance to like maybe unwind some of the really bad stuff, right? So like we all know that Senator Hawley was like, let's refund Medicaid. Cool. So we're not gonna do that because we want to like make him pay a price. Like that's not really how to do it. Like I think Democrats should come to the table immediately and stand for something and get something passed that like mitigates the harm to states and communities. Whatever. I don't know.
Yeah, I agree. And then claim the credit. Like, what? I'm confused.
Claim credit, right? Like you have to
Like,
win an
yeah,
election in a few years, dummies. Like get
like
working on
use
it.
the power of PR to show everybody how you got the thing done. I'm
I
confused,
know.
but
Why are they
whatever.
not
I
like
guess,
paying us to be their number one like consultants? I don't know why. It's weird.
I guess, they might not be one of our 7 million loyal fans. I don't know.
Weird.
We should call them.
Weird.
I'm not sure which
Weird.
one. Melissa, call them and see if they want to donate.
I don't think that they do. I just call them dummies, so I'm not sure if it's
You too can run your political campaigns in the Health Tech Talk Show. We will take your money. Call
that's
us
right.
now. Anyway, hopefully these guys aren't dicks. I don't know, whatever. Okay, yeah, then I mean, all the stuff continues, right, about the one big beautiful
Yeah.
bill, and people kind of it's a big bill. So, it's big. So not
Yeah.
everybody totally knew what was going on right away. And it looks like things are going to be a little dicey for our friends in hospitals. So
Yeah, like
there's
I
been
feel
a
like
lot
it's
of
a really bad year to be a hospital or a health system. I mean, you got all this stuff, this like massive, massive cut to Medicaid, huge amounts of increase in uncompensated care projected. People simply won't be eligible for Medicaid anymore. A lot of hospitals in lower income areas or areas where people had less employer-sponsored insurance had gotten pretty good at like signing low income people up for Medicaid and helping them get coverage and then getting some compensation for the care they were providing. And now you're going to have just an even larger amount of uncompensated care, number one. You're going to have states like broke all kinds of limitations on things like provider taxes and state directed payments in ways that they were trying to get coverage for care in places with higher Medicaid populations. And then in the CMS proposed rules, they're really taking aim at some of the things that have kept safety net hospitals in business, controversial as they are, like 340B, where they were like basically like getting
Mm.
this margin on drug pricing somehow. It's a weird, convoluted structure that's been much discussed. And I don't agree with it, but I also understand that it's like what's keeping safety net hospitals open in many cases. So you can't just like take that away and not have another solution. And the, rural hospital fund is not nearly enough to solve the problem for every hospital. It doesn't cover every safety net hospital, obviously. So just like lots of hits across the HR1 OBBA, and then all of the CMS proposed rules on physician payment schedule and also on the hospital payment system. And like, it's just, there's a lot of stuff in those proposed regulations and in the law that are like, yikes, not a good year to be a hospital or an insurance
Yeah.
payer. Payers and plans also not great. So like,
Yeah,
no
I mean,
go.
I think there's some little sparkles that I think I included in screenshots coming forward. But Melissa, I just saw you did a thing on the Incentive Slack about the big, beautiful bill in the rural. Sorry, I just brought you up here and like didn't tell you. And the Rural Health Transformation Fund. And I am delighted that there is a Rural Health Transformation Fund. That's great. Super pumped about it. But I think the analysis you did, or something you read, or something you included, I closed it so I can't find it anymore. Is like there's still a $36 billion gap or something
Yeah.
like that.
And
Like
then
with
yeah, there's a
yeah.
$36 million gap with the fund included, and then how the timeline runs is going to be additional 5 years after the funding runs out. So they're just screwed, basically.
Yeah, not great.
That's my
Seems
analysis.
reasonable. Yeah. Yeah.
She's all
Not
in
great.
summation, they are screwed.
Yeah.
Not great. Yeah. But I do,
She's gone.
who knows? Maybe, yeah, I did,
She kicked her back
I
off.
do think the big D Democrats, maybe they can pull some shit off with some of this other stuff and like maybe not ruin rural healthcare in America. I don't know. We'll see what happens. But this also, I think, did you send this to me, Lisa, or did I
I
actually
think I
read this
did,
on,
yeah.
did I read this on my own? I don't know. But this guy, who like, I don't think he's like a Republican, but whatever.
Farzad?
But he I don't
I
know.
don't think he's
He
a
does.
Republican either.
If you read this post, he actually outlines some ways that the proposed physician fee schedule um, kind of does something that you love, Lisa, which is puts some emphasis and money back into primary care. He also trashes the skin substitutes scam, which he highlights again as like the outrageous growth, and applauds CMS for that. So. I thought this was overall like kind of a good read. Go check out his stuff. I don't
Well,
always
so
agree with what.
AAFP kind of said, so basically what the Medicare physician fee schedule does is it basically rebalances the focus on primary care versus specialty care more or less. It doesn't add like net new payments per se to primary care. And I think that, AAFP and others who are primary care advocates were like, primary care is like flat out not paid enough and you need to pay like net new dollars to primary care. Okay, I mean, fair
Yeah,
enough. I think that they did try to sort of rebalance in this new physician fee schedule. So, I mean, TBD. I think it's a good start. I think quite frankly, it does show that the administration is um trying to implement some of the stuff that we've been talking about and everyone's been talking about for years. So,
I feel like we should take credit for that. I'm sure they all watch our
yeah.
show. Yeah, he says, and it's a long post, so we'll maybe link to it if we remember to do our post-show recap. But he says the skin substitute reforms alone could drop costs by 90%, moving from the biologic designation to incident to supplies. Yeah, manufacturers drove costs from 250 million to 10 billion through novel industry
That's
practices.
crazy. Wow. Wow.
Woo! That is like not a joke. So yeah, and then he
A
talks about
lot of money.
yeah. So go read our man's stuff here. It seems like he knows what he's talking about. Um, Also, Lisa, you pointed out that it sounds like Oracle pulled off a stunt here in the Milcon bill, which, by the way, I don't follow like military
Yeah.
stuff, but there is healthcare in the military. It's called the VA, and it looks like
And
Lisa,
the military health system. There's not just the VA, MHS and the VA.
there's like some money for the Oracle project.
Yeah, I mean, listen, here's the thing, right? When Cerner Oracle was awarded this, it was a long time ago, and it was a long time ago. And since then, there's been problems with the deployment, and things have been delayed, and like emergency brakes have been pulled, and it just seems to keep getting more expensive. So you can see here it says 3.5 billion for the Veterans Electronic Health Record, reflecting VA's announcement will resume new site deployments at 13 locations, growing to 26 locations in CY 27. This has grown quite a bit from the original estimates, and I think it will just keep growing. I really hope they can deliver this for less than all the money in the world.
I don't
Sorry.
know.
Love you, friends
Speaking
at Oracle, but like, let's get this cost down for America.
speaking of
Please,
speaking of skin
please,
substitutes.
please. Like, we can't afford it. We can't afford it.
Wah, 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 wah.
Yeah,
Oh, we
yeah,
got
yeah.
we got the Farzad fan club here. Hey, Pooja, what's shaking? Did you see the earlier part of our show? You should go see it. You would
Mm,
miss something interesting.
amazing.
Anyway, all right. Oh, we got our bestie Scott's here. Yeah,
Yeah,
yeah.
yeah, yeah.
You know, yep, yep.
Things happen.
Things happened. Things happened. Oh yeah. So do you all remember we had Jennifer Erickson on our show like a year
Oh
ago
my
or something?
God.
It was like a long time ago, and she was like on time. She advocates for an overhaul of the organ procurement system. And she outlined some like really awful cases. And I believe HRSA was supposed to rebid the whole I think the big organization is UNOS.
UNOS.
They're supposed to like totally redesign the organ procurement system in the U.S., which is like crazy, considered to be quite corrupt. It kind of got like stalled, sadly, in the last administration, and it looks like much like the Democrats should co-opt some changes to healthcare in upcoming legislation. It looks like the Trump administration has decided to co-opt this, and God bless them for it. Thank God, because this sounds like some awful freaking shit. Like we heard from Jennifer about it, and I think there are some crazy stories that have emerged along with this announcement this
Like
week.
listen, Secretary Kennedy says some stuff that I absolutely do not agree with, and he says some things that are truly sound crazy to me. Unfortunately, this tweet is not one of them. This is factual.
Yeah,
This is not like crazy, and this is factual. Unfortunately for everyone in the world, this is factual, which is horrifying. This was like so like HHS did the research, did an investigation, and then also like many news organizations did investigations. There was a whole write-up, a whole story in the New York Times, like
yeah,
interviewing people who like were almost dismembered, like while still being like it's not a fake. This is unfortunately for all of us not fake news, and this is a factual tweet from Secretary Kennedy that is horrifying. That is just
yeah.
disgusting. Blah.
It's pretty awful. I actually invited Jennifer to a dinner recently, maybe a couple months ago, and we were meeting some new friends. And man, this girl could not keep from talking about people having their organs harvested while alive. And I'll tell you, it kind of put a damper on the
Kind of brings
dinner.
the mood down.
Yeah, I was kind of like, wow.
Oh,
However, that's all real and good for her and people like her who are advocating for stuff like this for change because it sounds absolutely awful.
nightmare.
I do think the bummer right now is though you see all the people on the internet that are saying remove no take away your organ donor status because you're
Yeah.
just going to get your insides cut open. That's probably an awful outcome too because I think that
Right.
there are people who do need some of these life-saving organs and like in some cases you really are dead. So I don't know. This is awful. I hope they can clear it up. I hope some actual real reform happens. I didn't see what the outcome is of this announcement, like what they're actually doing, but I hope it's something real.
I mean, I don't know. This has been this has been happening for a long time, and ever since, I mean, when I started working in the federal government and studying health policy, now, well, more than a decade ago, uh, it was already known that the system needed reform, and had probably been
Yeah.
known for the decade before that. So, like, I don't know that. we're going to see some dramatic, I mean, I hope we see some dramatic change because this is horrible. Once you've lost that trust, like, I don't know how you get that back. That one's pretty bad. I feel like everyone can kind of relate to this like horror story idea. It's pretty simple. They're
Yep,
cutting me
not
open
ideal.
while I'm alive still and aware of it, and they're taking my organs out. Like, that's a
Yeah.
nightmare.
Jesus Christ. Yeah, not
Mm,
ideal.
not good.
But in like happy organ news, I don't know if you saw our bestie friend of the show, Dr. Darshak Singhavi went to visit 34 Lives, I think it was called, which is an organization that can actually revive, I'm probably not using the right words, kidneys that are otherwise would be thrown in the trash. So he had a
Nice.
post about it with a picture of him and Claire Jershow. I think her name changed. I may be getting that wrong. I don't remember. Anyway, Claire, go
Uh,
find Claire on the internet, and they went and did a site visit. And I think ARPA-H has funded this organization, and they actually, while they
nice.
were there, actually saved a kidney that otherwise was going to be thrown in the trash, and
What?
it was flown out and actually was transplanted into a patient. So apparently, like I forget the stat, but it's a lot of these kidneys are thrown away because they're not considered viable or they're damaged in transit or something like that. So that's at least a bright spot there. So
Nice.
great job, friends in the federal government.
That's right.
Um, I don't even want to talk about this. Do you?
Listen, here's the thing. Here's the thing, right? Like I think work requirements have been terribly, terribly implemented. It's a horrible idea when you look at the actual data. I understand why it might feel like something that we should be doing and ensuring, but I also know that like the number of people who are like sucking off the system is very very low. I do think that there is some reality to the like making sure that states are like checking, addresses and enrollment. There's some kind of check on duplicate enrollment across states, which is, I would imagine, very rarely like an intentional thing and more likely just a like slow and broken administrative systems thing. So I just, again, I don't believe that people who are on Medicaid don't deserve healthcare and whatever else. The problem with work requirements is that they have a chilling effect on people getting care, and that's if that's your choice, if that's your intention, okay, there you go. The administrative systems we have for this stuff are so bad. If you read the actual stories about the implementation of work requirements in Georgia, actually, Kat, there's some great stories about people who are like, I am literally working and I am trying so hard to prove that I'm working, and like the system is broken and it never works and it never takes, and like I can't get internet and I can't do, like, it's just, what do you do? It's not helping. It's not helping.
Yeah. Well, do we think Chai is going to fix this?
I do not know, but they are at least trying to get people together who have the kind of AI technology that could be used for this. And they're trying to like set some guidelines out up front. It's totally voluntary though, right? Like the federal government, they don't have to take this, they don't have to use it, right? It's um
Yeah.
it's going to be like a voluntary, like, here Medicaid, like here's CMS, here's a suggestion from like technology providers, folks who like have AI tools, like the guardrails we think you should adopt. So I think from like what Chai is doing, I think it's fine. I just don't think that the implementation is going to be very helpful for making sure people actually get care. The end.
Yeah. Um, lol.
Bummer. Super
Also,
bummer.
Kamal notes in our on screen chat here that 34 lives is there are 34 kidneys a day that could have been dumped that they are trying to save. So
Nice.
that's nice. That's nice. Thanks for the note there. Probably should know more about that.
Nice.
Yeah. Also, I heard AI is going to solve interoperability, so I'm excited about that. I feel like
Hmm.
we knew this, but United Health Group is saying, "Oh yeah, we are getting sued," like, or we're under investigation. So I guess now the secret's out, even though it was out.
Yeah, I mean, it's kind of weird that they were before saying like, we haven't heard from the federal government. It's like, okay, I mean, but then they were like, so we called them and they said we're under investigation,
I
which is like
mean,
not great either. Like, not great on all fronts. Like, which one is it, guys?
oh man, so good.
Oh,
Okay, yeah. Speaking of AI solving interoperability, I think this is actually a pretty good post by Brendan. I think I actually read this one on my own, Lisa, in the internet. But
you
yeah, he
did.
basically, I mean, Brendan, sometimes I read his posts and I'm like, what the hell is this guy talking about? Like all the all like it's like standards, blah blah blah, blah, blah. And I don't know how this stuff works, Lisa, but I actually feel like he's been like coming over to the dark side, aka our side lately, which is like, hey, none of that really totally matters. Like, let's just like get to results and move on. But he makes a good point here that like if we focus too much on these specific uh, ways of doing things, that we're gonna miss the big picture. So nice, thoughtful post. Also, trash is fire a little bit, which like I mean, I'm always into it when anyone has any drama about anything. So I'm kind of like,
There's a lot of debates right now about fire and whether we're focusing on the right things. And I think Brendan, who probably was up all night with his new baby, just wrote like tossed this one off in the middle of the
yeah.
night. I'm just guessing.
Listen, I do some of my best work when I am with sick children and not sleeping. So who
That's
knows?
right.
Who knows what's going to happen? Brendan may write a book on maternity leave. We don't know. Congratulations to Nikita and team, Fortuna Health, which does a lot of Medicaid work, which is awesome. They raised 18 million Series A. Andreessen was the lead. And Lisa, you had a comment on Nikita's post about this that I thought was really good about like skating, like totally skating where the puck is going.
Yeah, I mean, she is somebody who clearly has a lot of passion for the area, but she also was like a bit more of like a techie person, and then spent literally a couple of years just like digging into every aspect of Medicaid enrollment policy and all the crummy systems and all the crappy forms that don't work and all of the like broken, rat holes that they send people down, whatever. Like, and just genuinely like became an expert on the policy issues and the legacy technology issues, and then like built a company and got it funded in just like a couple of years. It's pretty impressive. And so she
Yeah,
was
that's
thinking
awesome.
about these issues around like enrollment and, eligibility, like all the specifics around eligibility for Medicaid, like a couple of years ago, and like talking about it quite a lot. Like very, very, obviously passionate communicator, but also like was like Medicaid eligibility, Medicaid eligibility. Like she wouldn't stop saying it. And this was like, I don't know, 3 years ago, 4 years ago. And so I
Yeah.
appreciate her like definitely skating to where the puck was going. Like very impressive.
Yeah, no, very cool. And I also think like what's cool about this A round is that everybody's like, Medicaid's over, right? Don't start a company that's working in Medicaid. And here Nikita is like seeing an opportunity, which I think is great. Like, yeah, I think you might not be able to get the $10 banana as a organization that previously sold technology to states. I'm sure that world has sunset. But if you're an organization like Fortuna, you can go in there and like do things cheaper and better and like awesomer, because you don't have your entire fee structure set up to screw the state
Yep.
government. Just saying. So congrats.
Technology first approaches without the legacy sort of tech debt and the sort of structure that requires you to be doing cost plus or whatever everywhere. That's pretty great.
Yeah, you go, girl.
That's right. Yeah,
All right,
impressive.
we're gonna bring on a special guest here. Seems like she knows stuff. So
She knows stuff. Hey,
welcome to the show. Welcome to the show.
y-
So oh, what?
you're
Oh, there we go.
unfortunately muted. There you go.
Yeah.
All right. So listen, you gotta tell our loyal fans. Just give us an intro. What have you been doing? Where are you at? Like, what even happened in your life so far?
Yeah. It's a lot. It's a lot to cover. So I'm a medical oncologist and a hematologist. That's my background. So I am one of these like classically trained, ended up in the lab for years kind of physicians. And so I was at Memorial Sloan Kettering. I did my fellowship there and then joined a lab there, which was a really great experience. But I was like learning how to code kind of like through YouTube videos. And at some point, I was like, okay, if I'm going to learn how to do research, I should actually like really learn how to code, really learn how to do this. So I went up to Columbia School of Public Health and I was like, hey, I want to get a master's in biostatistics. And they're like, that's fine. Like, we'll teach you how to build a statistical model. If, I was doing all of this research in genomics and clinical correlates. And they're like, we'll teach you how to do all that. We'll teach you to code, but you got to take all the public health classes too. And I was like, okay, fine, fair trade. And when I got there, I sort of realized like, oh, actually, I really love public health. We were talking a little bit earlier about where we're from, and I had done residency at the University of Michigan, which is like a big, flagship public university with a huge school of public health. And I'd done med school in North Carolina at UNC, another big, like, flagship public university, huge school of public health. And I kind of realized when I was at Columbia that public health had always just been automatically infused into clinical practice and research for me. And when I entered the world of oncology, what I was doing was kind of creating that bridge because it just felt so normal to me. And so after my time at Columbia, I sort of started thinking, like, what are the other ways to bridge an interest in public health with my background in oncology? And that made me think of the cancer moonshot. So I was really fortunate. I got that phone call one day from the White House, and they invited me to come and be the oncologist for the cancer moonshot. And while I was there, they had a whole health outcomes team. And I was like, you guys don't have a physician on the health outcomes team. And here I am, like, do you guys need a general doctor at the same time? And so I got really lucky, and I got to wear both hats for about a year and a half, there at the end of the Biden administration. And it was just an incredible experience, such a wild ride. And I'm just so thankful for, the people I met and the lessons I learned. It was just an incredible experience. Yeah. Since then, been doing a lot of traveling, and been doing some, consulting, a lot of it just sort of like, spending my free time thinking about a lot of the issues that really came up for us while we were at the White House. Things like, what's going on in the cell and gene therapy space, how do we advance things in global oncology? So it's just been really nice because I think there's a lot of people who are still really passionate about the work that we were doing together. And now we're just finding different ways of doing it, outside of government.
Well, so on the cell and gene therapy thing, obviously you're probably tracking CMI's model work there. Any thoughts about, like, share with us how that's going, like how if their approach is matching what you were hoping, like tell us about that.
Yeah. I think the CMMI, you know that team, but I think that they did a really great job in terms of being thoughtful as they put this all together. So I think Ellen Lukens, Lori McWright, they put together a great team, and really showed, incredible forethought when they were designing the model. So, for people who don't know, this is the CMS Cell and Gene Therapy Access Model, CMMI. And the idea is, you know, um, how do we try to, like, actually improve access to these therapies while decreasing cost as much as possible? And so, they had to figure out, okay, where are we going to start? There's so many, gene therapies that are coming out. We need to pick one that actually makes sense for a CMMI model. So they started in sickle cell because, there's 100,000 people in the country who have sickle cell disease, and about 60% of them are on state Medicaid programs at a cost of around $3 billion a year. And so
Wow.
if we're going to look for a place where we can really innovate, sickle cell, it just sort of made sense as, like, this is the right place to start. And they built it as, this idea of, well, the federal government is the 300-pound gorilla in the room. And so instead of each state Medicaid trying their best to negotiate with Bluebird and Vertex to get a deal
Yeah.
on, the sickle cell therapies, they're like, well, what if we just centralize it? The federal government will do the negotiation for all of the state Medicaids who want to participate. And then they were also really thoughtful in that they were like, we're going to build this as an outcomes-based agreement. So they actually are putting in place ways to follow up with individual patients. A lot of that work is being done by CIBMTR, which I know well from my days as a leukemia doc because they have a huge transplant registry. They do a lot of the cell therapy work as well. So in this collaboration, they're collecting data on these patients. And if patients aren't meeting the outcomes, well, then they're going to expect a rebate back from, Bluebird or Vertex and sort of say, like, you missed the mark with this therapy. Um, I think that was such a smart way of doing it because in sickle cell, around 90+% of patients on each of the trials that were published and that got them to FDA approval, around 90% of those patients, they hit the outcome. And so it's not that we're expecting a lot of people not to get the clinical benefit. It's that if we're going to produce this model, we want to create the infrastructure so that if in the future we're trying to use gene therapy that's less effective or maybe where it's harder to get to that outcome, the infrastructure is already there. And now we can sort of plug and play, make it easier for Medicaid patients in the future who are getting gene therapy for other indications. Um, So it was really thoughtfully designed. Bluebird and Vertex came to the table and they were like, yes, let's play ball. We'll do this. And then CMMI put out a call to the states and said, okay, who wants to participate? Like, you can still make your own individual agreement, or you can come in with us. And here's all the things that we're going to give you in this package deal. And they made it sound really exciting, and 35 states signed up. And the really great thing is that, I think Administrator Oz came out and was like, look at this incredible thing that we're doing in the cell and gene therapy space. And like, that's sort of like the biggest home run, is that, administration to administration, the
They're
focus
like,
needs
this
to
is a
be
great
on,
idea. Like,
Yep. Claim
whatever.
the
yes,
credit.
take
Claim the
it,
credit.
take all the credit,
Take the
like,
credit
keep,
if you want to. That's right.
keep doing
And
the
and
work.
it's
Yeah.
it's interesting, Kamal, you say like, they had a choice, the states had a choice to participate or not. Like the biggest states in the country are participating. So that shows you that
Yeah,
it's not even like literally California, Texas, and New York and
yeah,
Illinois, like a bunch of big states are participating, and Florida, sorry, really big, the
yeah,
biggest states in the country in terms of population. You think, well, doesn't California have like enough people that it's worth it for them to do it themselves? No. They like
no,
it's not worth like this kind of thing is like that's quite the endorsement for the biggest states in the nation
Yeah.
to join this, because
yeah,
they're the only ones who feasibly could like have any kind of negotiating stance with these, advanced biologics and the cell and gene therapy companies. There's no, they're all part of this model. It's just
yeah,
like, and I think it's also really cool that they're gonna like potentially build this infrastructure, because this is by no means like the first or the last where you have these really,
yeah.
really high cost treatments, whether it's CGT or something else. Like I'm thinking about, remember X number of years ago, it was like Hep C, right?
Hmm.
Just hugely expensive, huge Medicaid population who had
Yeah.
hepatitis C, finally curable, and just like bankrupting state Medicaid,
Oh,
right? Like just
yeah.
so bad. It's the same thing.
Yeah.
Yeah.
I mean, I'm really glad that so many states did decide to participate. I think again, like, it's a show of confidence, and it's also a sign of, like, they had the option. And I think like Massachusetts might be one of the states that decided to go on its
That's
own.
right.
Yeah. And
Why?
they,
Like,
well,
bro,
They
like
always say
maybe
what
they
they
what
got
are
a
want.
you
better
guys
deal.
doing?
They
Oh my
always
Maybe
say
they
what
God.
they
have,
want.
I don't know. Yeah, right. Those people in Boston, they aren't going to listen to anybody. So,
That is true.
Mm.
So
yeah.
amazing.
Yeah, so I think the idea that there is this continuity is really, it's awesome.
Yeah.
And I think there was also that FDA cell and gene therapy roundtable that they had. Vinay Prasad hosted it. Now it's maybe been like a couple of months ago. And I thought that was really great to see as well. Seeing that, okay, great, CBER is sort of taking a leadership role here. I think we were all sad to see Peter Marks go. But if Vinay Prasad is willing to have people around the table to at least listen to the issues, to let both academics and people in industry talk about what their concerns are, and is keeping the door open to making policy that makes sense for patients, I think that's a win, all around. Um,
Yeah.
so so a lot of really promising stuff happening in that space.
Other
Yes.
conditions that could be applied in a model like this, where the federal government is negotiating on behalf of the states.
Yeah, I'm sure there are. I think about this mainly in the gene therapy space, but CMMI has made a lot of models to try to, like, figure out, like, how do we actually use the centralized power that we have. Another one that I worked a little bit, CMMI, as you know, Lisa, is the one who's really, running point on these things, but I was glad to sort of talk through with them a little bit. Their oncology model that they have for value-based care. So a little bit, different in the way that it functions, but the idea of, how do we bring value-based care to oncology, and how do we make sure that we're providing these wraparound services that people have 24/7 access to a clinician, that everybody's using an EMR, but also using guidelines, that they're collecting patient-reported outcomes. And CMMI sort of doing this second generation, enhancing oncology model, taking what they learned from the original oncology care model, really trying to drive forward in this space and see, like, towards the end of the original oncology care model, they did start to see that they were reducing costs while improving or maintaining quality. So how do we take those learnings and move them forward? And I think, CMMI is doing a really great job trying to figure out what that looks like.
One of the other models and one of the other approaches now of CMMI under Abe Sutton and CMS generally is around how they can start really using technology and potentially, finding ways to pay or work directly with technology vendors and tie that to outcomes. So today
Yeah.
was the due date for the wiser model.
Um,
Don't ask me how I know. Yikes. And
oh,
one of the many reasons why my day was
Wah,
terrible.
wah.
But it is, I think, I don't recall, and I didn't like fully fact check myself here, but I don't think that CMMI has had a model where the technology vendors themselves were the participants, certainly part of
mhm.
teams and things like that. But in this case, they were really asking for technology vendors to apply as model participants. And there's some like fuzziness there because that model works in the way where basically like they're doing prior auth without doing prior auth. So like technically you're in the experiment if you are a Medicare administrative contractor in that region, or you're a provider who covers Medicare in that region, like you're going to be part of it whether you like it or not is kind of what they're saying. But it's voluntary because vendors are applying to apply their technology solutions to this work. So it'll be interesting, but there's also I think what we are seeing, what they've told us as well, of course, just like with CGT, is that it's going to be really, really, really focused on outcomes, right? Like
Yeah,
you only are going to be getting paid for these kind of things if you're truly, improving the quality of care, reducing the cost of care, ideally both.
yeah,
And they're really trying to like track those carefully. And that's hard. That's accountability. And that's not like, doesn't fit like like we were just joking about before, the cost plus model of contracting with the government. Like that's
yep.
not it. Yeah.
Yeah.
Yeah,
I'm not gonna just
Opportunities
pay
for
you.
new for
Ooh,
innovation. I'm here for
that's
it.
right.
Yeah,
Yeah, let's
that's
do
right.
it.
Cost Plus is
Boom.
sweet. Like if anyone wants to pay me on Cost Plus, I'm definitely into it. Just telling you, like
Well, that's what I'm
Putting
saying.
it
Like
out
great.
there.
there was
Yeah.
a long time where I was like, you know what, I got to figure out this like government contracting situation because man, oh man, you get a
Cost
government contract
Plus.
and you're set for life. Jesus Christ.
Ugh.
Just
But
relax.
anyway, so how are you enjoying the private sector?
Oh, well, I do really miss seeing patients. So, I'm hoping to get recredentialed and go back to seeing oncology patients for a little bit of my time at least.
Nice.
And then,
Awesome.
with the rest of my time, just got to figure out what the right fit is going to be. It's also been fun talking to folks in just in general public health and trying to see what's going on there. And then the global oncology work, I got to be honest, so interesting. That was a big push that we had before we left the White House, was trying to think through, how do we help low and middle income countries that don't have the same access to resources in oncology, but how do we help them get to the same outcomes? How do we help them get,
Mhm.
the treatments that are actually the most effective? And, what does that look like? Um, Part of what we had done to sort of set the stage for this, it was just so fascinating to see, like, how do you think about what the US is up to geopolitically, and then try to say, how do we actually advance what we care about, which is, science, medicine, and specifically for us when we were working in cancer, using all the work that's sort of already being done. So, there were a bunch of big state visits from the Prime Minister of Australia, the Prime Minister of Japan, and the Prime Minister of India. And they all came through the White House sort of together in this big clump. Like, I think it was over the course of 6 months. And they came and they were sort of like, hey, President Biden, you have an initiative named after yourself or after your son that's focused on cancer. We have a huge issue with cancer too. We don't necessarily have the same resources in the same way that you guys do. How do we work together? And so, hearing this from three different countries in such a short time span, we were sort of like, oh, well, there's a huge opportunity here. Like, people want to have this conversation, people are bringing this up. And so, we actually worked with those three countries, with America being the fourth, because they were already forming the Quad. And we were like, let's turn it into the Quad Cancer Moonshot. And so we actually negotiated with those different countries to figure out, if we want to do some work in the Indo Pacific focused on cancer, as opposed to all the other geopolitical stuff you're doing, what does that look like? And so we had all these conversations about, where do we start? And we landed on cervical cancer. And
Hmm.
so each of the different countries were sort of like, India is like, we have the Serum Institute. We know how to produce vaccines for cancer. We could produce the HPV vaccine and make it cheap. Japan is like, we have all this technology. We could help figure out, technology for diagnosis in the Indo-Pacific. And Australia was like, we're a country, but we're also a continent. And so we've developed this really great ground game. We could help you figure out how to actually implement cervical cancer screening, vaccination, and treatment plans because we know how to do it in a variety of contexts throughout our continent. And so coming together, we sort of formed this partnership, and the US was going to be the one, like with the US Navy, to actually sail to the different Indo-Pacific islands and administer the
What?
vaccines and administer the
That's
screenings.
so cool.
Awesome.
And so, yeah, and so that sort of formed the first platform for the global oncology work, and now there's just lots of iterations that are still going forward from that. So really cool to see how this work kind of continues on. Leaving the White House, but still a lot of people who are really interested in seeing it through.
Yeah, I love how positive you are about all this. Like you're just like, we're going to figure out a way, and people are still doing it. Like, who are some of the groups who are taking on that work now that it's
Yeah,
non-government?
So Catherine Young, who was another assistant director at OSTP within the Cancer Moonshot, she's really leading this effort, and she's just been doing a phenomenal job. And ASCO, the American Society of Clinical Oncology, they've also sort of said, global oncology is a real interest of ours, and we really want to step up and support this work. And then there's a lot of discussion in the background to see, who else might still be interested. Former colleagues from the WHO and the World Bank who were interested before, are they still interested now? And how do we leverage those connections and that interest and push things forward? Lots of academics who are doing this work as part of their, practice already. Trying to work with them and say, what relationships do you already have? What is the work you're already doing? How do we join forces? And how do we create something bigger as a whole, as opposed to the individual parts? So it's just been really cool to see everybody who had an interest, that interest is still there. This is work people still believe in.
Awesome.
Yeah, I feel like in another lifetime, it actually was very close, very like a sliding doors moment around like being involved in you know public health on the front lines. And one of the things you didn't put in your slides, Kat, which makes me very sad, is the threats to the U.S. Public Health Service,
Oh,
which is like
Oh yeah,
very.
I
So
apologize.
there was a moment during the first Trump administration when I, a career employee, actually went through and applied and actually went as far as like having my medical done to join the public health service as
wow.
a commissioned officer. And literally, like right before it was finalized, I had been like already down selected. It was getting real, like, oh, like
Wow.
why, like super, super real. And they cut the funding for new officers like right
Oh,
before. And those the US,
Wow.
I know, Kat, you didn't know this. The U.S. Public Health Service is freaking awesome. They're like commissioned officers, uniformed officers who
yeah.
do all kinds of public health work. They have like day jobs, usually in HHS policy in different ways or whatever, different types of implementation across different agencies. A lot of folks in the Indian Health Services, but they like go everywhere. They were the people who were
Yeah.
Yeah.
deployed out to like Ebola response, all the COVID
Yeah.
response. They don't get to choose. They just go and do the response wherever it is and like keep people safe and are super incredible. And like, I just, like the idea that that would be threatened, those people are already like working their butts off for very little money and like are not
Yeah.
afraid to go out there and like respond on the front lines of any type of public health crisis, whether it can be something like, global battle against cancer or, a new pandemic or whatever else it is, like they're doing that kind of work. So, yeah, please
Yeah.
don't cut them.
I know.
Please. Please.
Yeah.
Like
I know it.
we really like we need them and they're like serving
Yeah.
America for real, like
Now
real
you
No.
time.
sent a really good. You actually sent, and I apologize I didn't include it, but yeah, you sent a really good. I think it was like an op-ed, someone's LinkedIn
It was
post.
from Brett
Mm,
Giroir, who was
Um,
the Assistant Secretary for Health under Trump one, and
yeah,
he in his role, you take on a leadership role in the public health
hmm
services as the Assistant Secretary for Health, I believe. And so no, I mean he was like, "Hi, I did this during Trump one. Like I promise you guys, this is good. Like this is positive. Please don't
it's
cut it.
not bullshit. Public
Not
It's
health
not
is in
bullshit.
the
bullshit.
title, but it's like
That's
not
It's
right.
really
that.
good.
It's real. It's like
It's
they're doing
real.
things.
Oh, God.
Please. Yeah.
Yeah, 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 yeah.
I
All right.
knew
Well,
um I knew a guy at the FDA who was part of the public health corps, and he told me stories about during COVID getting deployed. I live in New York City, got deployed to the Javits Center here, and they had
Yep.
to figure out, like, they were like, the doors are going to open, there's going to be a flood of people. how do we build an electronic record system? So
Yep.
they called up Apple and they were like, hey, can you guys give us some equipment? And Apple was like, sure, we have all these iPads that are sitting there. Nobody's buying them because it's COVID. We'll just send you a whole pallet of them. And so dude gets this whole shipment of iPads and he has to figure out like how to put an EHR on it, how to train everyone to use it, and then keep track of all the different people who come in to get
Wow.
vaccinations and care during COVID.
Yep.
But yeah, it's just like incredible work. Just drop these people anywhere and like, yeah, let set
That
them
is
off.
some GSD. Love it.
No, they're genuinely amazing, and like they did such incredible work on behalf of the US for the last, I don't know, 100+ years that it's been around, and like especially in COVID, especially in Ebola, like yeah, I don't know. A lot of people who are like, yeah, I'd love to go and be right on the front lines of that. Give me a paper mask. I'm in. And they were there.
Yeah, yeah,
Yeah.
for sure.
Amazing.
For
Amazing.
sure.
Well, Kamal, so you've told us a lot of things that you're really excited about. We've got 5 more minutes until our loyal fans go to the bar or whatever they're going to do. Tell us one more thing. Like, what are you super pumped about? Because I love your vibes. I love the GSD vibes you got going on.
Yeah, I mean, I guess like the other thing that I was super excited about, and I know you guys were talking a little bit about the VA, and I do hope that the VA gets additional funding to be able to do some really good work. But a couple of the initiatives that they had, there's a doctor named Vita Passero who's out in Pittsburgh. But she put together this huge decentralized care platform at the VA. And the cool thing about the VA is that it's the largest integrated health system in the country, right? And so, because the physicians there don't have to worry about whether or not they're licensed in a different state, they can do telehealth with any veteran in the country.
So
So,
crazy. Yeah.
they came up with this concept of like, oh, it's really hard to get subspecialty oncology care to people who live in rural areas, but we want to make sure those vets are getting excellent guideline based care. So they created this whole system of just, providing telehealth based on a person's diagnosis. So, Dr. Passero in Pittsburgh could be seeing somebody who's in Idaho or North Carolina who happens to need a specialist that matches her area of expertise. So, okay, they solved that one problem. And then they thought, okay, but it becomes a problem because, like, what happens to this patient? If I write chemo and I'm like, this is the treatment that you need, how's that patient going to get it? Because they're not coming from Idaho to Pittsburgh. They're not coming from North Carolina to Pittsburgh, right? That was the whole point of the visit in the first place. So they created this second program where they essentially train oncology nurses, like chemo nurses, to go anywhere in the country. And then they can go to the local clinic that VA has that serves that veteran. And they can sort of show up and be like, hey, all you got to do is come from home to the normal clinic that you come to anyway, and we will give you the chemotherapy there. And then the nurses are trained on what to do. Everybody's made aware of the side effects. They're communicating with the physician through telehealth. And they've saved vets like hundreds of thousands of miles of travel because of this. And they've treated vets
Right on.
all across the country. Thousands of vets are now able to get access to this kind of care. And so they've been, slowly scaling it up. And I'm really hopeful that continues on. Because, like, we talk a lot about like, how do we remain patient focused? We had a whole clinical trials push at the White House. How do we really create systems where we're meeting people where they are? And the VA was just like, we got it figured out. And they actually implemented it in a way that no other health system in the country can. So, I think the VA and I'm super excited to see the innovation that they have and sort of like how they're trying to be on the cutting edge. The resources that they do have, the things that they can do, how do they do them better than anybody else? And they really figured out this specific niche. And it's just no one else in the country, I think, has come close to what they've done in that really innovative way.
Yeah. It's almost like we shouldn't have to worry about how healthcare is paid for. I don't know. Drive me crazy. Co-sign it.
Listen,
Co-sign it right
yeah,
now while you're tired and you
we
can't.
Yes.
You can't focus
no,
when you're too tired to figure it out. Come
I'm
on.
so
Come on.
tired, you guys. Kamal, I like love everything you're saying. I'm like sleepy, but
It's all
no,
good.
everybody, I've already told everybody I'm pro single payer in a Medicare Advantage model. Lisa, we're not going to get in a fight because I agree. What?
I don't know. It's good.
Nothing to
No,
fight
I
about.
agree. The VA and also in many cases the Indian Health Services have been like They've done more with less. They've done more
Yeah.
with like minimal
Yes.
technology and support, but they're just like, we have to serve this entire population. And there's definitely a
Yeah.
lesson there of like, you've got to be able to figure out the right solutions that aren't like limited by like payment or jurisdiction or whatever. It has to be like,
Yeah.
how do you get the right outcome for those people you're serving? So I think they're definitely a model for that, for sure.
Yeah,
Yeah.
I think it was just, the most impressive thing to me about my time in federal service was, this idea that health policy really can be used to achieve great things for the country, and just seeing different iterations of how thoughtful health policy actually did improve health outcomes for people. Like to me, I was like, oh wow, the impact can be very real.
So
Nice.
would you go back into the government?
I would love to. I think, when the time is right, when the position is right, when there's a fit, if I can use my skills to help, serve the country through the federal government, I would jump at the chance. Yeah.
Nice. All right,
Yeah.
Boom.
Kamal, bring her
Love
on.
it.
We're
All right.
ready.
Okay. Last words for our loyal fans, Kamal, before they go off to the bar.
Oh my God, it's so hot in New York. So get a cold drink and strap in. Make sure that you're paying attention to the health news. I love the way that you guys set up the talk shows. But thanks so much for having me on. It's been
Thanks
awesome.
for
Thank
coming. Have a good
you.
weekend, loyal fans.
Have a good
Boom.
weekend, everyone. Bye.
Bye.